your brain releases a hormone called thyroid-stimulating hormone. So that's what that TSH stands for. And its job is very similar to how it sounds. It's meant to stimulate the thyroid. And so it sends a message to your thyroid gland, and then the thyroid gland should respond by producing those T4 and T3 hormones. Now, the brain essentially gets wind of what's floating around the system and determines how much of that thyroid stimulating hormone it needs to produce. So if the thyroid is under functioning, it's not producing enough thyroid hormone, what happens is the brain, like you said, essentially starts to yell at the thyroid gland. It releases a ton of thyroid stimulating hormones. We see those TSH numbers go upwards.
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast. Hello, everyone, and welcome back to the Advanced Women's Health Podcast. I am so excited to dive in with Dr. Micaela from our Brooklyn clinic today, and we're talking about thyroid function and hormones. Getting into this, we were talking, okay, like what do we want to dive into? And one of the things Micaela pointed out is we haven't talked a lot about thyroid function, which I think is hilarious because NDs are just like known for the thyroid function piece. But it's so true. And so I wanted to take a bit of a different spin. Obviously, we will outline for you what is the thyroid, how does thyroid function show up? But what we're really going to dive into is hormonal health and aspects of hormonal health that can come up with thyroid dysfunction. And Micaela, we talk every day pretty much on our clinical rounds calls. And Micaela was talking about a case this morning where it was actually this patient, yes, they have endo, they have other things, but it was thyroid regulation and giving thyroid medication that solved a lot of menstrual problems. And I think it's just something that's not really well known, to be completely honest, how much of an impact that has. So yeah, I'm excited to dive in today.
Let's do it.
Okay, so let's take it away and get started with what is the thyroid? When we say thyroid function, what does it mean? Why are NDs known for loving thyroids?
So the thyroid is a gland in your body. It sits in your neck. It looks like a butterfly, which is what I typically tell people. And when we talk about thyroid function, what we're talking about is your thyroid's job and how it's doing its job at producing thyroid hormones. So it's a hormone. And typically what happens and how I explain to my patients is there's a hormone that comes from your brain called thyroid stimulating hormone, and that stimulates your thyroid to do what it needs to do. And there's two hormones that are predominantly released from your thyroid gland. Those are T4 and T3. And that's when we talk about thyroid function. Why I think NDs are known specifically for dealing with thyroid stuff is that although there are very clear diagnoses of an overfunctioning or an underfunctioning thyroid, so producing too much hormone or producing too little hormone, there is a bit of a gray area in there, I think. And sometimes not everyone who might be suffering from a bit of thyroid dysfunction fits into those boxes. And so there are lots of tools that we have as NDs that can help with thyroid function that doesn't necessarily require the same criteria of diagnosis as, say, the medical community might require before initiating treatment.
And it's funny because we say, oh, there's a clear sets of diagnoses, but I feel like that even more so than ever is kind of untrue. So there's a clear set of normal and abnormal on labs, right? We've got your TSH being high, which I'm going to get you to explain what high and low mean in a minute, because that is always a brain energy utilization situation for patients. They're like, high means low and low means high, and I don't know what I have, what's going on. But when we look, so in our units, I think in the US as well, TSH, thyroid stimulating hormone, we want to see it. If it's less, is it less than 0.4 now?
0.32. Oh, I don't know. Maybe did it change?
I know. That's why I don't know.
Well, okay, I
Anyways,
think it's 32, 0.32.
okay. Okay. So less than 0.32 is diagnostically your TSH is low, meaning your thyroid is functioning over the top. And then depending on where you're at, it's like over 4, over 4.5, over whatever, you start to flag as high, meaning your thyroid is not functioning well and your brain is screaming at your thyroid. Okay, cool. But we have patients that are flagged high and it's like 10 and the doctor's like, yeah, you're fine. So I think this is where like the diagnostic, the range is very clear. Here's what's high and here's what's low. How people are using it is still wildly variant, which is kind of crazy to me.
Yeah, even within the medical community, you have doctors who will initiate treatment as soon as it pops over 4, and then you have doctors who are waiting until it hits 10. And not to say that anyone's necessarily right or wrong, but when the person in front of you is suffering and something is coming back abnormal, why is there not a discussion around options to make someone feel better? That's the part where I feel like we do a really good job at being like, hey, you're not feeling well and this is not functioning well. That might be the reason why you're not feeling so well. And then we can look at what treatment would look like.
Yeah, I'm like, I hate to be this person, but if a man's testosterone comes back a little bit low and he can't get an erection, like we're the first ones to jump on that bandwagon. But you know what I mean? When a woman comes in and her TSH is at 6 and she's gaining weight, exhausted, constipated, brain foggy, XYZ, it's like, oh, let's just watch it wait. So again, like I don't want to be that person, but
there's a lot of watching and waiting, and these symptoms could be explained by other things, right?
Yeah.
And it just makes people suffer for longer, which sucks for them.
Absolutely. And I want to be clear, like as much as I can be savage at times, there is, as we all laugh internally, the reality is there are people who have a TSH of 4 or 6, which means, again, and I'll get you to break this down very specifically in a minute for anyone whose brain is scrambled, that your brain is screaming at your thyroid because your thyroid doesn't want to work. I do have patients that start medication and do not feel a difference because that, just like any other hormone in the body, thyroid hormone does not work in isolation. If you have a raging inflammatory condition that's causing your thyroid to be dysregulated, if you had blood sugar dysregulation that is spinning out of control, if your nervous system is a mess and you're not sleeping or you're perimenopausal, it's not going to fix all of your problems. But at the same time, if you're chipping away at a block of challenges, that's a pretty easy one to tackle for the mass majority of people.
Totally.
So let's break it down. High TSH, low TSH, hypothyroidism, hyperthyroidism. I'm asking the pregnant woman to break it down. No, I'm joking.
Well, I can do this. This is why I have a whiteboard on my desk, because this diagram, I should just like have the diagram on the wall because I draw it so often. But essentially, in very simple terms, as I mentioned earlier, your brain releases a hormone called thyroid-stimulating hormone. So that's what that TSH stands for. And its job is very similar to how it sounds. It's meant to stimulate the thyroid. And so it sends a message to your thyroid gland. I point to my neck because that's where it is. And then the thyroid gland should respond by producing those T4 and T3 hormones. Now, the brain essentially gets wind of what's floating around the system and determines how much of that thyroid stimulating hormone it needs to produce. And so it's a feedback loop. So if the thyroid is under functioning, it's not producing enough thyroid hormone, what happens is the brain, like you said, essentially starts to yell at the thyroid gland. It releases a ton of thyroid stimulating hormones. So we see those TSH numbers go upwards. The opposite is also true. If the thyroid gland is putting out way too much thyroid hormone, like it does in hyperthyroidism, then the brain will start to very, very quietly I've never thought of like, what's the opposite of yelling? I don't even know. But it will essentially turn
It's not
down.
even whispering. It's like a mute. It's
Yeah,
like, no.
well,
Like, don't do anything. Just sit
yeah,
in silence.
it'll start to get very, very low. So it is opposite.
It's like what happens when you're in a bathtub and you have toddlers. You just like sit there in absolute silence and hope they don't hear you.
Put your hands up. But yeah, so it's actually opposite of what feels like would make sense.
Yeah. Yeah, because I know that's the thing that people say all the time is they're like, okay, so my TSH is high. I have hyperthyroidism. And I'm like, no, because the thyroid stimulating hormone is not the hormone. And I think this is the piece that confuses people a lot is your brain is responding to the amount of hormone produced in most and many situations, right? And everyone will always say TSH doesn't mean anything. That's also like very popular in a lot of medical worlds, whether that's conventional, naturopathic, functional, etc. TSH doesn't mean anything. And I'm like, no. TSH means everything. TSH is so sensitive. It's just we may not know what it's sensitive to. And that sensitivity may not be helpful in diagnosing the patient, but it doesn't mean that your brain doesn't know what to do. It just means that you could have more hormone at the level of the brain than you do in your body for a variety of reasons that we will probably not get into today because it's more complex than it needs to be. But I think it's a very important conversation to have is that your brain is always sending a message that it believes is accurate and appropriate. And we see this a lot with low levels of TSH, maybe not diagnostically, but on the very low end of the range. Someone's brain is not telling their thyroid to work, but their hormones, their T4 and T3, when we measure those, they are also. And so in that situation, your brain thinks the most appropriate thing to do is cause your body to not make hormone, to cause your body to downregulate, to be sleepy, to go to bed, right? There's something called non-thyroidal illness or sickness syndrome, something along that way. But it's essentially when your whole thyroid axis is downregulated. Your body doesn't want you to make thyroid hormone, but it has nothing to do with the thyroid gland's ability to do it. It has everything to do with underlying infections, inflammation, things like that, stress, insulin, etc., that's causing your brain to downregulate hormone production. So what are some of the symptoms people have when they have hypothyroidism? So their TSH is high, they have hypothyroidism. What are some of those symptoms?
So when we think about the symptoms, I always relate it back to what the thyroid does. So the thyroid is essentially like controls the metabolism of almost everything in your body. So if we don't have that support, everything tends to slow down. And so things like constipation, weight gain can be incredibly common. We do see a lot of fatigue. Sleep issues are also incredibly common. And circadian rhythm changes. I know that we're going to get into this, but cycle-related changes, so irregular periods, heavy periods, missed periods can also happen. Then we can kind of get into a little bit of like, not that they like, because they're very common, but they're not as well known. I wouldn't call them like the textbook symptoms that people are looking for, but things like cholesterol coming up on lab work can be a really big clue for people. Itchy and like hive type symptoms can also be connected there. Migraines, headaches, those types of things, body pains, aches. Like as I'm talking, I'm like, oh my gosh, there's so many. It's like, what does it not impact? But yeah, lots of, essentially it can almost impact everything, but those are kind of the big ones. Did I miss anything?
I don't think any big ones. No hair fall.
Oh, hair loss. Yeah, that's a good one.
Yeah, hair loss is another one too. And I think this is one of the reasons I think there's this tendency to talk about complexity. Like people are just complicated. It's overwhelming. There's everything is impacted, so nothing's important. There is sometimes that tendency. And whenever you're dealing with hormones, and I am up to my eyeballs in perimenopause research right now, so I'm going to probably relate things to perimenopause more today than I have before. But you look at that, for example, there's been this conversation forever that there's the main symptoms, just like there's the main thyroid symptoms, and then there's the main perimenopause symptoms. Hot flashes, night sweats, dry vagina, dry ass. Like that's it. But you have a receptor for estrogen on every tissue in your body because it's a hormone that's important. We have a receptor for thyroid function on pretty much every tissue in the body. And so if that's the case, then everything from your hair, and this is what I always do when I'm looking at thyroid function, is I like go head down, right? So you're like, okay, hair loss, brain fog, fatigue, like you go down the list. But with you do the same thing with any hormone. You look at cortisol issues everywhere in the body, thyroid issues everywhere in the body. And so I think because they're so generalized and sometimes what we call subacute, meaning the itty bitty shitty committee. It's like they all go together. There's a little bit of them and they just rise and rise and rise and rise and rise slowly. You don't wake up overnight in perimenopause. You don't wake up, well, for most people, you don't wake up overnight with hypothyroidism for most people. And so in that situation, so many people just don't feel good. They don't feel horrific, but they don't feel good. And because it's not one system of the body and it's not one concern or complaint, it doesn't get captured in the way it could be in a visit because the system in Canada has made it such that it's a one visit, one problem thing. And if you come in and say, my problem is my thyroid, then that can trigger a whole bunch of feelings for the provider on the other side of the table saying, well, I'll make that diagnosis. If you come in saying it's constipation, you're going to get Metamucil and Dulcolax. If you come in saying it's heavy periods, you're going to be offered an IUD or the birth control pill. If you come in saying it's hair loss, they're going to say, okay, let's test your iron and go to a dermatologist. So you see what I mean? Like these multi-system problems is really the work of a naturopath, to be completely honest, because they can never be solved with one problem or one concern, which is honestly one of the big takeaways I think is important for people.
100%. Yeah. Putting the pieces together.
Exactly. And so
and
then when
the
it comes
to do so, right?
Absolutely. Absolutely. When it comes to hyperthyroidism, what do we need to know there?
So a lot of the symptoms typically are opposite of hypothyroidism, but not necessarily all of them. So people tend to have trouble putting on weight, or they lose weight quite quickly, have a pretty ravenous appetite. Palpitations can be incredibly common, although those can also happen on the other direction too. Feelings of like anxiety can be huge. Insomnia can be a big one in this population too. And then there can also be all of those more like inflammatory type symptoms like the joint pain and stuff like that. Cycle related changes as well. So typically we're seeing more missed cycles with a hyperthyroid population as opposed to heavy and or more frequent. But again, things can go different ways there too.
So then what are the causes? Like when you're breaking it down, let's stick with hypo. So in hyperthyroidism, we used to say it was very rare. The causes were mainly around like postpartum, perimenopause, a traumatic incident. There's an autoimmune condition called Graves. It's very specific. I don't think we can get into both and do them well today. Now we're seeing it more because of post-viral thyroiditis, which is again a conversation all in its own. So let's stick with hypo for the purposes of today. So for like low functioning thyroid, low thyroid hormones, what are our causes? What are the things you're looking at when someone comes into the office and you think this could be happening?
So the number one thing I'm looking for is something called Hashimoto's, which I think oftentimes people don't necessarily understand the difference between hypothyroidism and Hashimoto's, or they just like assume it's Hashimoto's because the TSH might be off. But the biggest difference there is that there's an actual autoimmune component to it. So parts of your immune system, at some point, due to various risk factors, have decided that your thyroid gland should be something that should be attacked. And so immune cells are attacking your thyroid gland, which over time allows it to not work as well. And so thyroid hormones start to decrease. So that's a big one. I want to say that's like upwards of like 80% of cases. Like it's a big one. I do see cases where people don't have positive thyroid antibodies, but it's not as common for sure. I would say like another thing, how we talked about at the beginning about with the low thyroid hormones plus the low TSH is almost this like something that's suppressing the system from doing its job, right? So that could be long-term chronic stress. So that could be mental emotional stress, but also physiological stressors. So inflammatory triggers, which can come from the gut or other immune system changes. We can see like post-viral type changes, which again, we're seeing a lot of that now. So like the thyroid is incredibly sensitive. And so every time the body is under stress, the thyroid gland is going to be impacted in some form of way. So, but I think those are kind of the biggest ones.
Yeah, it's having been in practice almost 10 years now, which is craziness. Like, where did that go? I've seen so many patients where they come in, their thyroid hormones are low, their TSH is a little bit high. We support it. They then either get pregnant, get a virus, hit perimenopause, and their antibodies were negative before. And now what's happened is we call it seroconversion, but essentially those antibodies have become positive. So why is this important? Your thyroid it's what we call a capsule. So if you picture, right, it's encapsulated, right? I'm like, how do you describe that in a better way? Like you picture it's in its own protected little unit. It's got lots of blood flow, but it also has support. And so because the damage to the thyroid is happening inside the capsule for most people, it's happening to those little tiny cells. Sometimes the antibodies don't leave that capsule. They don't get to escape and get into your arm. And this is what I say to people all the time. It's like, we're taking blood from your arm. Your thyroid is here. That's not necessarily close. So if it's high circulating in your arm, it's definitely high around your thyroid. And if it's not hot, like if it's high around your thyroid, it doesn't mean it's high around your arm. So in some of those situations, we will say it hasn't converted to the serum, right? Serum is what they take out or what they can assess from your blood. When they take your blood, they can assess it and break it into serum. So it hasn't seroconverted, meaning it hasn't showed up in your arm yet. And so it is a very important thing because, yeah, I would say probably 70, 80% of them. I used to say 80 to 90, but we've definitely seen some weird changes in the last 5 years in thyroid function. So I would say probably 70 to 80% test positive today, but that will absolutely with time shift and change. And we'll see those people have those antibodies become positive. And if you do an ultrasound on the thyroid, sometimes you can see that immune activity. You can see that there's some damage to the tissue itself, which that also confirms the presence of an autoimmune reaction, meaning your immune system is damaging the thyroid itself by accident.
Yeah, I definitely had conversations with patients where we like are almost sure that it's going to come back as Hashimoto's and their antibodies look fine, but it's like their parents had autoimmune conditions or they've had autoimmune stuff in the past. And it's like, okay, it might not look like this now, but like you might be one virus, one accident, one baby away from things changing. And like that's important to consider in your health, right? And also in how you're feeling too, right? Like if you're not feeling well, then why wait? Right? Why not be proactive on stuff like that?
And I think the other thing, I love that you're having those conversations because I think the other thing that's important with that too is when you look at the process of treating the autoimmune process, it's literally just the process of getting your body better. And so why wouldn't we? You know what I mean? Why wouldn't we focus on all of the steps that we need to focus on in order to get someone to a place of health, autoimmune? So I think it's such an important thing. So let's dive into the hormonal connection before we get into how we think about treatment and what we do. That hormonal piece, because again, we do see those irregular cycles. We do see heavy periods. We do see some of these things. How do you see that show up in your practice?
So with hypothyroidism specifically, it doesn't necessarily always go one way or the other because you can have select people who actually get very frequent cycles, like their cycles are quite short. You can also have people who miss cycles entirely. And I think, we've talked about this before and it's been talked about on the podcast, is that every hormone affects every hormone. And so we can't necessarily say exactly what direction it's going to go, but essentially depending on what it's affecting, we can see people getting their cycles every 2 weeks, every 3 weeks. We can see a lot of spotting that can happen between cycles. It can happen around ovulation. It can happen leading up to the cycles or nearing the end of cycles. So yeah, it can, and then typically we do see them be quite heavy, especially if they tend to come more frequently. And so those are kind of the biggest things that I see is like the irregularity and then heaviness are kind of the big ones that do
Yeah.
come up.
And this is something that it's funny, I don't think I've actually done a ton of research on this. As I'm sitting here talking through it, I'm like, I'm glad that we're having this conversation out loud because everyone gets to see that I don't research everything. Sometimes there are things that you just know to be true. But what are some of the mechanisms? Like, why is that happening? Obviously, I can speculate in my head, but I'm going through and I'm like, I don't know if I've seen the exact statistics on this.
I'm sitting here being like, if she asks me the exact mechanism as to how the thyroid impacts it, and in the back of my head, I'm like, okay, should we bring up insulin? Should we bring up like ovulation and like all these things? It's just so funny. But I think because it goes back to like those hormones affecting every hormone, right? So, I mean,
Yeah.
one thing that comes to mind is you can sometimes see high levels of prolactin with hypothyroidism, which can impact ovulation. And so then you can get irregular ovulation. If we're seeing, more frequent periods, again, what's happening from like brain hormones, like follicle stimulating hormone, like how is that being, produced? And then I think about how we have to think in the sense of thyroid conditions, there's oftentimes a lot of inflammation, right? And so is the inflammation impacting egg quality? Is it impacting the ability of your body to ovulate? Is it impacting receptors for hormones? And are we getting lower levels of progesterone leading to spotting and heavier cycles? And I think there's just like, I'm like picturing this web in my head and I'm like, oh my gosh, then the liver can be affected, which can affect estrogen metabolism, which means periods can be heavier and you can miss cycles. And I think that just there's so many ways that it can impact your cycle.
Today's episode is brought to you by none other than Advanced Women's Health. If you are interested in diving in deeper to your health, if you are finally ready to feel like yourself, and you are finally over hearing everything's normal, everything's fine, and you want a deeper dive into your healthcare, then we are here to help you. We are currently helping patients in British Columbia and Ontario, Canada. But don't worry, if you're in another province, still reach out, get added to the wait list as we expand coast to coast. We cannot wait to work with you. Check out the show notes for more information on how to get started.
I don't think we've done this on the podcast. So let's jam through this because this is what we do when we are talking about cases live on a call. There's what we know in the research, there's what we know in practice, and then there's how do you freaking explain that, right? Like how do these things gap together and what's important and what's not? Because the reality is in women's health, there is very little amounts of research. This is facts. And as you're going through, and it's because being a researcher, working on animal models in the past, there's certain things you just don't think about. And one of them is the fact that we do not use female mice in the lab because female mice have periods. And that introduces variability that can't be controlled. And therefore, we're using, for the most part, male mice. And it's funny because you go through the research, there's like a specific type of mouse model that they talk about. And if you read through these research studies, it says male, blah, 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 like this specific type of mice. And I was sitting there and I'm like, holy shit. You cannot ethically do research without like some kind of mechanism. Either it's a mechanism that you see show up in human health that we've hypothesized, done many reviews on. If we have some kind of ethics on it, like there's a reason to do those studies, there's a reason to dive in. But if we're only studying males, then if you take out a thyroid of a male mouse, you can see a certain impact, which will then trigger us to ask certain questions, which will then make it through to ethics to allow human studies. But there's huge gaps there if we're not doing it with female mice, understanding female mechanisms. It was something that's occurred to me recently. And I was like, you know what? That actually kind of makes sense. But anyways, alas, what we do on our calls is say, here's the reality. The reality is VC patients do have all of these symptoms when they have thyroid dysfunction. And here's the science. And here's the gap. And so how do we fill that gap? Right? And so let's just jam on that for a minute before I spin out too hard. When we go through, your thyroid, as you said, is involved in energy production. How is it involved in energy production? It is giving your mitochondria the power and the energy it needs to be able to make more. This is why people can get stuck in a loop of dysfunction. Okay, well, those mitochondria make our hormones. They make estrogen, they make progesterone. They're very important. So thyroid gives energy for us to make things. Then we look and we say, okay, well, they're, to your point, inflammation. Autoimmune conditions are very involved. We also know that there is T3 and T4 and anti-TPO in the ovaries. So there is a cross relationship between the antibodies that attack our thyroid and the antibodies attacking the ovaries in many situations. Not many, some situations. And so we can see ovarian decline, ovarian damage. Okay, well, that would be a source of short cycles. That would be a source of spotting. That would be a source of dysfunction of the ovaries. And then you're right, like you just kind of go through the list and you say, okay, well, there's no energy. We're not able to make the hormones very well from a mitochondrial perspective. Then we're going to see now there could be damage to the ovaries. We see that there's no energy for ovulation, right? So this is how we kind of go through the list, is you go through and you look at each different step of the hormonal network and how it's showing. So we've got that. Let's get into the heavy periods piece. So short cycles could be that your brain's not talking properly. It could be that there's damage to the ovaries themselves. It could be that you are ovulating early or not successfully ovulating and bleeding. It could be that you can't maintain adequate hormone levels. And so you're getting breakthrough spotting kind of throughout. What about heavy periods? Like, how do you think through that?
So two things came to mind in terms of heavy periods. One was the connection between hypothyroidism and insulin resistance. So a lot of women who experience hypothyroidism for various reasons will also have insulin resistance, and that insulin is a growth factor essentially. And so you can see like essentially more thickening of the uterine lining. And so that itself can lead to heavy periods. The other thing I thought about, and this goes a little bit more back to that mitochondrial hormonal production, is that if we're not getting adequate progesterone during that second half of the cycle, or if something's impacting that ovulatory piece, we get a lot of unopposed estrogen, which again leads to that thickening of the lining. And so cycles can be quite heavy in those situations as well.
Yeah. Progesterone is so important for what we call like differentiating or making that lining ready to come off. And this is something that I think a lot of people don't understand is the lining, aside from very rare people, the lining doesn't just come out, right, with your period. It's actually breaking down and dissolving. And that's a really critical piece because your body is able to repair and like manage the blood flow. It's able to manage those vessels because it's dissolving. It's not like coming off like a scab. And I think if you have situations, and it's a visual that I tell people, if you have a situation where you peel off a scab before it's ready, what's going to happen? You gush blood because the blood vessels underneath are not ready. They're not properly matured, all those types of things. Whereas if you have a situation that the skin is like slowly healing and peeling off, then you aren't in that situation. And it's not a perfect analogy, but I think it's a good enough one to think through what can happen and why people can bleed so heavily. Because again, that lining was not ready to come off. And for some people, again, like as someone who has not had very heavy periods in my life, and I had a couple heavier ones recently for a number of reasons, I was like, what the hell, right? Let alone I have some patients that sit on the toilet and it sounds like they're peeing because of the amount of blood loss they have. So this can be extreme. It can be so significant and so impactful to their quality of life that I don't think it's something that most people understand can be supported by supporting their thyroid function if their thyroid is off.
Totally, especially in like that perimenopausal phase of life. Like I feel like it's just, oh, well, you're perimenopausal, of course your cycles are heavy. And it's like that we know is a vulnerable time for the thyroid to change its function a little bit. And so I'm always like telling women like it's something we have to test because like you don't have to necessarily sit and suffer, right? And if there's something underlying what's going on, it's important that we provide support because it can be such an impact on someone's quality of life and being able to leave their house and stuff like that.
Absolutely. So obviously, without giving away any specifics, the patient we were chatting about this morning, so she came in for heavy periods.
Yep.
And we believe she has endometriosis as well, right? If I remember correctly.
Yes. Yeah, we're pretty.
And so what was that process of diagnosing and supporting her thyroid function? Because again, I think this is a perfect example of where, yes, if you go to you might have heavy periods, you might have weight gain, fatigue, constipation, etc. You go to the doctor, your TSH is flagged at 6, you get medication, you may or may not feel better. That's another conversation. But it's very easy to diagnose, but walk us through a little bit more about what happened in this situation.
So yeah, with every patient, the first step is always the investigation piece, right? And so in her situation, I remember at the end of her first appointment, I think I mentioned this in our call, is that she had been diagnosed with an atypical PCOS. And so we gathered as much information as we could about her cycle and her health history, her parents' health history, who actually both also suffered from thyroid conditions. And I was pretty certain that she had endometriosis at the end of our conversation. And from what I remember, it's been a couple years, but we started working more on that endometriosis piece while we were waiting for lab work to come back. So getting the lab work was an important part of our investigation work as well. And she didn't respond as well to some of the endometriosis stuff that I would have anticipated if that was the only thing going on. And interestingly enough, she was in a situation where her thyroid antibodies were not positive. And you're like, darn, I totally thought that was what was going to explain everything. But we were able to actually get in a lot of the labs that her doctor had run. And it seemed like her TSH continued to fluctuate up and down. So sometimes it was, 1.43 up. One time it was 3.95, which is right about that point where it's getting flagged. And so I believe we first tried some nutrients and herbs that can support thyroid function, but eventually, just because of the level of her 10-day heavy periods that were impacting her life, we had a conversation about giving her thyroid hormone, and she was like, you know what, at this point, I'm open to anything. Let's see what happens. And I'm pretty sure her cycles went down to about 6 to 7 days within a cycle or two, which was 3 to 4 days less of bleeding. Okay, yes, we would like to get them maybe down a little bit more, but that was pretty significant considering there hadn't been options for her other than get an IUD or let's get a birth control pill, right? Ultrasounds were coming back. Pelvic ultrasounds were coming back normal, and those were her options. And so we were able to kind of investigate, be like, hey, it doesn't look like you have Hashimoto's, but it's so likely based on your presentation. And we can talk about that fluctuating TSH if that would be helpful in a second. And then we were able to look at hey, we can treat this like endo, we can treat this like a thyroid condition. We can start with nutrients and then go to thyroid hormone if we need to. And she was just a person where that's where we needed to go. And it's been incredibly helpful for her. And it's not like she came in with typical symptoms, wasn't overweight, wasn't losing hair, wasn't overly fatigued. And it was just so interesting that was, the piece that really, really changed things for her.
Yeah. And before we get into the fluctuant TSH, because I think that's a really big thing, there's a couple things I want to highlight there. One is you had the luxury of time to go through all those past labs and recognize that fluctuant TSH. You're not taking a one-off set of labs and saying, okay, here's what's going on. Labs are just a data point, everyone. I'm sorry. Labs are just a data point, everyone. It is such an important thing that we have the ability to look at is say, what's happening over time? What is the pattern telling us? One is a one-off, two is like something, three is a pattern. And so we look and we say, what's going on over time? And what is that telling us? And so many of all practitioners, naturopaths, nurse practitioners, doctors, everyone are not looking at patterns. They're looking at a one-off. And I think that is such a critical piece to the puzzle, is understanding what's happening over time. So that's one. And two, you will notice that Micaela didn't say, oh yeah, the patient came in after the first visit, miracles happened, fireworks went off, we're great, everything was solved, right? Like sometimes this takes time. And one of the things I said to a patient is that we love to get everyone a 2-week win. We love for something to shift in 2 weeks. That's great. But you're going to commit time in one way, shape, or form. You're going to commit time with me, giving me the opportunity to figure it out until I can't. And again, I think this is one of the things that I love about our clinic is the amount of integrity our practitioners have. If you're coming to me and I try things and I don't know what's going on, I'm immediately going to bring it to my team. And if I bring it to a team of almost 50 docs and they don't know what's going on, you know what I mean? Then we've got to refer out and we'll be the first people to tell you that. But you're either committing the time with me over time, or you're going to commit the time to 5 different doctors starting from scratch every time. It's up to you. But if you're committed and on a health journey, we're as committed with you. You can see a different doctor within our practice. You can see, like, you could move around and never have to start from scratch. But I have so many patients. I am the 6th, 7th, 8th, 9th, 25th doctor they have seen. And yes, sometimes they think I work miracles, but it's honestly just because I sometimes I'm lucky to have the patterns and the time to go through the patterns of all the other doctors they've seen and say, oh, here's what's missing. Or two, I'm just grumpy enough, I guess, that they keep coming back long enough that I can finally find out what's going on. But I just wanted to highlight those 2 pieces because I think that's what we're going to talk about cases a little bit more in the next little while, and like what we treated and how we treated it, because I think it's such an important understanding for people. Because if you haven't seen a naturopath or you've only seen one, it can be hard to understand what that experience can look like. So I just wanted to get into that because I think it's such an important piece.
Totally.
So what's this fluctuant TSH business?
So I know I mentioned it. I was like, we should talk about that. And this actually happens quite a lot, which is interesting, and it can be very helpful, especially when I've worked with patients for a while, to kind of look at these types of patterns. But sometimes what we see is that the TSH can fluctuate, and your TSH in an ideal world shouldn't really fluctuate too much, right? And so when we're seeing that TSH fluctuate, even within that normal reference range, like it's never really going above that 4, but it's 3.5 and then 0.8 and then 2.5, and we know that the thyroid is responding to something, right? We don't necessarily know what it is. If there's likely there could be antibodies present. So whenever I see a TSH is fluctuating, we always investigate that first. But there could be other reasons as well. And this is where, not that I think watch and wait is always a bad thing, but if someone's coming back with a flagged TSH and the doc is like, hey, we'll remeasure in, I want to say 2 months, but sometimes it's 6 months, right? We'll see what happens in 6 months. And then that TSH looks normal. It can be so defeating for that patient because they're like, I feel all of these symptoms of a thyroid condition, and now my TSH is normal. It was abnormal, and no one's going to do anything for me. But that does become significant, and it's significant that we're able to look at those things because that is abnormal, right? It's just that the immune system is acting differently. Inflammatory levels have changed. Maybe you were hit with a virus when the TSH was high, and now we've finished fighting that virus off, or stress levels were different. So that's a really important piece because patients can feel so defeated when their thyroid, quote unquote, comes back to normal. But also as a practitioner, recognizing those patterns and being like, well, that's abnormal and we do need to test further and monitor. And maybe we wait till you are sick or super stressed and be like, what's happening? Because the reality is those triggers are everywhere and anywhere all the time now, that if that's kicking off your thyroid to underfunction, that's significant for you.
Yeah. And I love that you bring up the defeated piece because You're right. And I honestly, I haven't really thought too much about it because I just treat whatever. If it walks like a duck, it talks like a duck, I treat it like a duck. But I think you're right, for so many people who don't have the luxury of this medicine, it is so heart-wrenching. And I tell patients all the time, they're in this space, they come in and they're like, just find something wrong. Find a number, find a thing that justifies how I feel, because it does two things. One, it again makes them feel like it's justified and that there's a path. And two, it helps them to communicate that. Sometimes our patients, when they feel so unwell, other people are like, well, what's going on? And they're like, I don't know. Everything comes back normal. And then again, they're told, okay, it's all in your head, move forward, blah, blah, blah. But people just, they want something to justify those symptoms, and they also want that path forward. So I think you're so right to point that out.
Well, thanks. I see it way more often than I wish I did, but
yeah, absolutely.
It happens. But it's lovely that we're able to open up options and get those people feeling better, right? So
absolutely. So then, to wrap up, what are the kind of top 3 things you think about and look at? And like, how do you treat when it comes to thyroid dysfunction? So you have a patient in front of you, you're trying to understand how you're going to support them. How do you navigate that? So obviously, thyroid hormone is an option. We've talked about that. But outside of thyroid hormone, what are the things you're thinking through?
So the first thing I always look at is the person's actual symptoms. And so I think that's a really important thing to consider, maybe the most important thing to consider.
Shocker.
Like, well, it's just like, I don't know. I have people who like have an elevated TSH and they feel great. And we've had the discussion and it's like, okay, we're not going to do anything super crazy about this, right? Whereas sometimes their TSH is 2.6 and you're giving them thyroid hormone, right? So I think how the person feels and how that's manifesting is the number one most important thing. And then the decision very much becomes, are there antibodies present or a likelihood that these could become present, yes or no? And then does the support need to go to the thyroid hormone production, or does the support need to go more to the immune system? Because in certain cases, especially if we're able to catch thyroid conditions early, we can calm down that immune system enough that there's no longer an attack on the thyroid and your thyroid can do its job beautifully, right? And so oftentimes that is step one, especially when I'm working with younger patients who come in for either regular periods, right? It's a great time to intervene because things are still quite early. Whereas sometimes if it's more later down the line, if there's lots of inflammation going on in the body, there is a certain level of damage that is a little bit harder to come back from. And so in those cases, we might want to be supporting hormones themselves. So not only just the antibody response, but the actual production of that T4 and T3. And then I break that into 2 separate streams. One is we give nutrients and herbs that support T3 and T4 production and conversion. And then the other stream is we actually do give thyroid hormone. And so that's kind of how I go about it in my head. And so some people will leave with things to help their antibodies. Other people, we go straight to thyroid hormone right away. Sometimes we start with one, give it 3 to 6 months, see how things are moving, and add on, extra treatments and stuff like that. But at the end of the day, there are certain patterns that you see, but there's also so much individuality in how people respond to things, right? And so some people you're like, oh, I don't think you're going to need thyroid hormone. And that's when things really start to change, right? Whereas other people, you're like, oh my goodness, like that TSH is really elevated. You're absolutely going to need to be on thyroid hormone forever and ever. And then, things completely turn around. So that ongoing monitoring is important, and looking at all those different things that can be supported, right? Like it's so much simpler, or so much not simpler, opposite of that, so much more complicated than just giving thyroid hormone when TSH is high, right? And when we figure out what needs the support and what those options are and understand how the patient wants to feel, we're able to kind of create that for people.
And you mentioned this earlier, but I think one of the things that I always go through is, how long has this patient had low levels of T3 and T4? Because as we were talking about, T3 and T4 is required for mitochondria and energy production. It's required for the liver and liver function. It's required for proper cholesterol metabolism in the body. So I think one of the things, those patients that are newer diagnosed, it is a little bit easier. So we can stop the antibody damage. We can support the gut microbiome, figure out any food triggers, figure out any viral triggers, and use the variety of herbs and treatments we have, from black cumin seed and selenium and inositol to antiviral herbs, etc. When I have a patient who's been not diagnosed for 10 years, right? They were never well since pregnancy. Nothing was ever caught, addressed, viewed as bad enough. We come in, we test their hormones. Their T3 is at 3, their T4 is at 10. You know what I mean? Their TSH is fine, but there's not adequate amounts of hormones. They often, to your point, have insulin resistance. They have a significant amount of dysbiosis. They're absolutely full of shit. Their liver is a mess. Their cholesterol is high, and they feel like everything is wrong. But the reality is, it's just, we have to do a massive cleanup. And I think that's where the complexity comes in too, because at that point, and this is why I love the medicine we do, but this is why a lot of people don't, is it's not about fixing the thyroid. It's like, okay, it's like if your house burns down, you know what I mean? You're not like, okay, perfect, the flames are gone. Like the house burned. You know what I mean? And I think that's the thing that can happen for people, is that their house has been burning down. We can put out the fire. We can reduce antibodies and get them thyroid hormone. But that doesn't fix the problem that is in place. And I think that is, one, an expectation that sometimes people have that is something that we need to deal with. But two, it's also a situation that we need to have that longer term relationship, because it's not just about the thyroid at that point. And I don't think people talk about that enough as well.
Totally. Yeah. Like everything's so connected, right? Like I always tell my patients, like it's a spider web, like everything is connected in so many different ways, and there's lots of work to do, but it does help to have someone who understands how it all fits together. Right. And help support those types of decision-making and treatment protocols and stuff like that.
And I always say, like, it doesn't have to feel so hard when you have a guide. When you have someone in front of you, as much as there are many steps and you're not going to get better in a day, if you know you're guided and in the right direction and you feel a little bit better every day, it's not like you feel like you're punishing yourself for the next 6 months. And I think that's something that's so important for me to emphasize to people is, like there is a rebuild process, but it's worth it and you can get through it. And we've done it with hundreds to thousands of patients, right? Like there is a system.
Yeah. Totally.
Amazing. Well, I think we will end on that note. This has been super helpful. I think even just for people to hear a little bit about how we treat and how we navigate things. If you guys want more of these episodes, let me know. Slide into my DMs. I would love to hear. The feedback is always super helpful. And thank you so much, Dr. Micaela, for just coming and chatting today. I love when patients get to know our practitioners on another level. And I think it's so much fun to keep them on track as well.
Amazing. Well, I had so much fun. Thanks.
All right. Thank you for coming. And for everyone, I will talk to you guys next week.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message. And that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.